can start,
Yeah, I think I'll introduce Dr. Jalal Ahmed. He is the director cum professor, Bangladesh Eye Hospital and Institute, Dhaka, and was formerly director cum professor, National Institute of Ophthalmology and Hospital in Dhaka. And he's a prolific surgeon, and he's going to talk to us. Dr. Manas, please come up. Please come up. Yeah. So we will start off with your talk. He's going to talk to us on posterior polar cataracts for 10 minutes.
Yes, respected chief instructor and instructor, dear delegates, very good morning and welcome you all to the my talk on management strategy of posterior polar cataract. Actually, there is a strong adherence of the opacity to the weak posterior capsule, and there is 7.1 to 36% incidence of posterior capsular dehiscence, and there is a high rate of operative surgical complications like PCR, nuclear drop, etc. And on slit lamp examination, diagnosis of posterior polar cataract is very easy, but full ophthalmic evaluation is essential. If you see something, some refractile small vacuole-like things in the anterior vitreous, it indicates there is dehiscence in the posterior capsule, and ocular and systemic association is to be excluded. This is a picture of posterior polar cataract with extending of peripheral extension and bullseye-like appearance, and with advanced technology like anterior segment OCT, we can see the status of the posterior capsule preoperatively and also paraoperatively in the operation theater. And counseling is very important before attempting surgery. Counseling is very important regarding the longer surgical time. There is a risk of PCR and secondary posterior segment intervention. Post-operative laser capsulotomy may be needed, and the visual recovery may be delayed, and there is in uniocular cases there is chance of amblyopia. Operative surgical management, several surgical approaches have been proposed to minimize or delay the risk of PCR during surgery. Anesthesia is like topical, peripulvar or GA according to the case. And incision side port should be 1 to 1.4 millimeter, and main incision from 2.2 to 2.4 millimeter according to the need of the surgeon. And tunnel should be self-sealing, stable, and a bit longer tunnel. And here the Hydra Procedure is sorry. Here rhexis is very important. Here rhexis is very important. Rhexis should be between 5 to 5.5 millimeter, and it should be circular and central, so that if any complication occur, so if any complication occur, we can capture the optic capture is possible. Then Hydra Procedures. No hydro dissection is contraindicated in these cases, and hydro delineation should be done to separate the epinucleus from the endonucleus so that the posterior part remains untouched during removal. And sometimes in case of hard nucleus, there is inside out delineation as suggested by Dr. Vashapada. It gives very good result. First sculpting is done, then from the side wall inside out delineation is done. Rotation, whether rotation is rotation should not be done in case of posterior polar cataract, because if you do rotation, there is a risk of, here you can see that there is risk of posterior capsular rupture. During nucleotomy, management of nucleotomy varies according to the hardness of the nucleus. In soft nucleus, or after hydrodelineation, we can remove the central part, and then separating the epinucleus, easily the soft epinucleus can be sucked out through the phaco tip. And all this time low parameters are used. In case of nuclear sclerosis, central sculpt is done, and peripheral a small peripheral segment is removed first, and then in the viscoelastic is injected to float the rest of the nucleus, and carefully the rest of the central part of the nucleus is engaged in phaco and removed. Then epinuclear bowl is with visco dissection, epinuclear bowl is separated, and then it is cleared. Phaco-parameter, regarding phaco-parameter, their aspiration flow should be low, both light should be low in manual cases, and vacuum should be very low and moderate to low phaco power. Here is a video showing all these steps together. The incision with good tunnel, the X is about 5 millimeter, 5.2 to 5 millimeter, and hydro delineation is done normally as there is nuclear sclerosis. Central sculpting is done, and after doing the sculpting, their peripheral small segment is removed first, then viscoelastic is again injected. Remember, mind it that each time you remove any instrument from the eye, inject viscoelastic first, form the anterior chamber, do not allow the anterior chamber to become collapsed, and carefully remove the central part and engage it to the phaco tip and remove it. And after removing the central part, inject the viscoelastics to make a visco dissection to remove the epinuclear bowel. From the limited visco dissection is done first, and then bimanual IA is very helpful in these cases. First, clear the part away from the incision, distal part of the capsule, epinucleus, and then clear the sub-incisional part of the epinucleus by gentle and slow aspiration using bimanual irrigation and aspiration cannula. And after clearing the cortical matter, then first remove the aspiration cannula, keep the infusion cannula inside, and then inject viscoelastic to form the keep the anterior chamber formed. Then implant the IOL in such a way that it should not directly hit the posterior capsule, so that posterior capsule rupture may occur, because in these cases the posterior capsules remain very thin. So any attempt should not be done to do anything near the posterior capsule. Then wound hydration is done to close the eye in a normal way. And it is the first postoperative day appearance. It is the first postoperative day appearance of the case. And in case of advanced technology can be used, femtosecond laser is very helpful in managing the posterior polar cataract. After proper capsulotomy, the 3 cylindrical incisions are given. First, the central part is removed, then next the epinuclear part, and the next epinuclear bowel is removed, and then with limited visco dissection, the epinuclear bowel is being in the center, and it is cleared in normal way. And there are still then there may be some complications. Here you can see dreadful complications where the phaco is started in a normal way, and the cataract is not so hard, but there is sclerosis in the frontal part. The nuclear after sculpting is done. After sculpting, on attempting the hydrodelineation, some fluid may go behind, and you can see that there is just nucleus starts sinking down, and that time surgeon stops any maneuver. Then the patient is shifted to the next OT, and vitreoretinal surgeon comes to help. Then with the help of fragmatome, the nucleus is removed. It is cleared out, and after clearing the nucleus, prophylactic laser was also given. And after doing all these things, intraocular lens was a 3-piece intraocular lens was given in the sulcus, and then it was optic captured as shown by the previous speakers. It is nicely captured in the optic of the lens. Optic is captured, and then there are some There are some no in case of posterior polar cataract. There should not be no dissection, no nuclear depression, there should not be no rotation, there should not be no collapsing of the anterior chamber, no posterior capsular polishing, don't hit the posterior capsule during intraocular lens implantation, and no overinflation of the anterior chamber, and no higher parameter phaco should be done. And thorough examination and preoperative counseling is very important. Vitrectomy equipment should be kept ready, and there should not be any hydrodissection. Maintain the uniform AC depth throughout the procedure. Last part to be removed is the central posterior part of the lens, and low phaco parameter and gentleness is of handling is mandatory. Thank you for your kind attention. Thank you.
Thank you, Dr. Jalal. That is a very extensive coverage of phaco in posterior polar cataract. Very, very well described, and thank you very much. Your videos were fantastic. And the last point, that injection of lenses into the bag, that also has to be done very carefully, because we tend to, once we finish it, we think it's all done. And the injection of IOL sometimes happens very coolly, and sometimes hydro. I've stopped now injecting IOLs under saline. Always it has to be under viscoelastic. And also I have had PC ruptures during hydration of wound. So when you hydrate, if fluid goes inside and it balloons, we don't look at that, we look at the incision. And I have had PCs open up at that stage also. So thank you very much. And we'll move